Good afternoon. My name is Susanna Gurr, and on behalf of the team here at the BC Centre for Employment Excellence, I would like to welcome you to our webinar today. Before we begin, please take a moment to answer the poll on your screen. If you are participating, and we know many of you are, with a colleague or in a group, please select the most appropriate or common answer. We will close the poll in a few minutes or so and let you know the results. For those of you who are not familiar with the BC Centre for Employment Excellence, it was created in 2012 with funding from the provincial and federal governments to act as a research and knowledge sharing organization for BC employment service providers and employers. The Centre's mandate is not only to do innovative research, but also to find ways to share that knowledge and promising practices with BC practitioners and employers. We created this webinar series as a way to reach out and connect with practitioners. Through this series, we have been highlighting new research by the Centre, but are also tapping into the knowledge and expertise within the employment services sector. You are invited to view the video recordings of previous webinars that we have posted on our website. Today, we are delighted to launch the first of a three-part series on working with individuals with mental health issues from an employment perspective. The series is designed to support career development practitioners in their work with clients with mental health issues. However, the content of the series will be helpful to all staff members in employment programs. The first of three webinars will provide a framework for employment and career practitioners to be more effective in helping individuals with mental health conditions obtain and keep employment. More specifically, it aims to increase awareness and knowledge of mental health issues. Just before I introduce our presenters, the results of the poll. 92% reported yes on our result, so that's pretty good. I would like to welcome and introduce our two presenters from Gastown Vocational Services. It's my pleasure to introduce Mariella Bolzer, who's a registered occupational therapist and coordinator of Gastown Vocational Services, a specialized service offered through Vancouver Coastal Health that assists individuals with mental health conditions to reach their employment and educational goals. In addition, she has been a clinical associate professor at the School of Rehabilitation Sciences at the University of British Columbia for many years. Mariella has extensive experience working with the specialized disability client groups in career development and case management, and she has gained a well-deserved reputation as an expert in the vocational rehab field. Dr. Sarah Jane Meechan is a clinical psychologist with a specialization in neuropsychology. Dr. Meechan has won multiple awards and grants in her career. Sarah's research has been published in esteemed peer-reviewed scientific journals and presented internationally at conferences. She is currently registered as a psychologist in Alberta. In the last 3 years, Sarah was a registered psychologist at the Glen Rose Rehab Hospital in Edmonton, where she applied her expertise in neuropsychology assessment and intervention to individuals with acquired brain injury, dementia, and psychiatric conditions. We are lucky that Dr. Meechan has returned to BC, and she now brings her expertise in clinical neuropsychology and rehabilitation to Gastown Vocational Services. Before I turn it over, I have a few housekeeping items. The presentation will last about 45 minutes. Due to the high number of participants, we will be muting the audience throughout the presentation to ensure audio quality. We encourage you to use the questions feature on your dashboards to submit any comments and questions. My colleague Greg will be compiling the questions for Mariella and Sarah to respond to after the presentation. We will leave about 10 minutes at the end for further discussion. We are recording the webinar, and we will post a video on our website along with a link to the presentation slides and with further opportunities for everyone to continue the conversation. With the high number of participants today, we might not be able to address everyone's questions during the webinar. However, the blog will be a great place to ask your questions and continue to engage with Mariella, Sarah, and other practitioners. If you lose your internet connection during the presentation, please reconnect using the link emailed to you. If you lose your phone connection, redial the phone number which appears under the Info tab and rejoin. Now it's my great pleasure to hand it over to Sarah and Mariella.
Thank you so much for that introduction, Susanna. It's our great pleasure to be here today to present with you. I'm Sarah Meechan of the pair here, and I'm going to be getting started. There's quite a bit of content to cover, so I'm going to just jump right in. So first, just a little bit of the learning objectives, what we're hoping you'll walk away from the webinar with. Firstly, we'd like you to understand why career practitioners and employment specialists need to focus on mental health. We're hoping that you'll have a basic understanding of the major principles of recovery and psychosocial rehabilitation, which we'll then build on in a later webinar. We hope that you recognize the characteristics of successful employment specialists as suggested by research. We'll give a basic overview of some of the common mental health conditions that may affect employment and some treatment options if we have time. And finally, we'll provide you with a list of internet resources related to mental health and employment. So, in approaching this talk, I was reflecting a lot on the changing landscape of mental health in Canada. How over the past 30 years, we've moved away from institutionalizing people with mental health conditions. There's also a growing recognition about how many people are impacted directly and indirectly by mental health conditions. So indeed, a third of Canadians will experience a mental health problem during their lifetime, and a fifth of Canadians will have a mental health condition or problem this year alone. So this is something that affects all of us. 6% of hospital admissions are for mental health reasons, and the economic burden of mental illness in this country is $51 billion. 20 billion of those are from workplace losses alone. In the workplace, mental health issues have a significant impact. And one of the documents I would encourage all of you to read is The Aspiring Workforce, which is a document prepared by the Mental Health Commission of Canada. One of the things I learned from that document that was quite shocking to me was that up to 90% of Canadians with serious mental health issues such as schizophrenia or bipolar disorder are unemployed. While their symptoms may be one part of why they struggle to find and maintain employment, stigma and discrimination are additional barriers to employment. Increasingly, persons with mental health issues are turning to disability income support programs. Now, although a financial social safety net is valuable and important, many or most individuals with mental health conditions both want to work and are able to work. The net result is that their skills, talents, and potential are often wasted. And finally, the fact that most mental health conditions emerge in adolescence or early adulthood, which is such a crucial time for education and building a solid foundation for employment, means that mental health is of particular importance to career practitioners. It's not all bleak, though. There's a lot of hope, and that's what I want our talk to be about. So a quotation that we speak a lot at Gastown Vocational Services is by the Greek physiologist and philosopher Galen, who said that employment is nature's best physician and is essential to human happiness. So we know from research, for example, that people with mental health conditions who work are hospitalized far less often. They use fewer mental health services, and they're 2 to 3 times less likely to commit suicide. All important outcomes. And you, as career practitioners and employment specialists and other staff, play a major role in those outcomes. Now I'm going to turn it over to my colleague Mariella, who's going to provide an overview of recovery and psychosocial rehabilitation principles.
Thank you, Sarah and Susanna. Good afternoon, everyone. I'm going to switch gears a little bit to talk about recovery and the importance of psychosocial rehabilitation, which I'll refer to as PSR for the rest of this presentation or seminar or webinar, and look at some of the principles and approaches that can be effective in helping our clients get back to work and stay in work. The goal, as identified by the Ontario Aspirus Society in PSR, is to support the fullest integration of individuals as active, productive members of his or her family, community, and or culture. The importance of recovery philosophy and PSR for mental health clients has been recognized and endorsed by governments throughout Canada and the world. PSR services are effective in helping clients in the areas of employment, education, leisure, and wellness. Today, we are focusing on employment. When we look at the PSR principles that guide our recovery philosophy, we are speaking to the principles of client involvement. Services need to be based on clients' needs, self-determination, the right of clients to have choices and options, the potential for growth, hope, which is such an essential ingredient in the approach of PSR, partnership with practitioners, and using a client-centered approach, and of course the focus being on function and wellness. So using a strength-based PSR approach focuses on helping the client to develop skills, effective coping strategies for wellness, and access resources and supports to be successful in employment and or their volunteer work. Volunteer work has been established in the literature and in research to be effective in helping clients develop the readiness or soft employment skills necessary for competitive employment. PSR approaches in supported employment need to be delivered in a consistent and quality manner based on best practices. Experts in the field of vocational supports for people with mental health issues recognize that there's ample evidence and support the concept of work or employment for clients. And certainly our clients wish to work and improve the quality of their lives. So as career practitioners and employment specialists, we can play such an important and significant role in helping clients get back to work and in their recovery journey. In fact, we should be privileged to work with clients and help them guide them to employment and put forth the skills and talents that they have to offer. So in looking at maintaining employment and a lot of the research that has been done in supported employment, I looked at some of the key characteristics that career practitioners can demonstrate to help produce more positive outcomes. The supported employment study I'm referring to was one that was done in Montreal, where there were about 70 employment specialists surveyed and about 100 clients engaged in the supported employment process. And they found some characteristics that were correlated with successful outcomes. Clients perceive the following employment specialist competence to be important: positive attitude, encouragement, flexibility and availability, the ability to offer support, to listen attentively, to be non-judgmental, to offer guidance, knowledge, and to be a model for the client. Also to be able to normalize situations, that is, take away the drama, and to give strategies. Also, being part of a team working collaboratively with partners was also demonstrated to be important. And when I look at the partners, I'm looking at the employers, the mental health treatment staff, family or significant others, and the other very important point that was identified was that
the employment specialist should have key marketing abilities, and these were all found to be key ingredients in helping the client be very successful in producing successful employment outcomes. So now we'll look at an overview of some of the major mental health conditions, and I'll turn it over to Sarah for this next part of the webinar.
Thanks, Mariella. Well, deciding how to frame a discussion about mental health is really difficult. The terminology is always evolving. There's lots of different ways to conceptualize mental health issues, and not everybody agrees on the best approach. We have differing perspectives on the origins of mental health conditions, and even within a single condition, different people can present in very different ways, so it's difficult to generalize. There are also issues of comorbidity or concurrent disorders, which we really don't have enough time to tackle. Fortunately, in my view, there are some things on which I'd wager all of us agree, and these are crucial in how we approach our work with clients. First of all, the idea that mental health is complex and the origins are also complex. So that is, there are likely to be biological, psychological, and social factors involved in the development of mental health conditions. I think most of us and most of you in the audience today would probably also advocate for a point of view that puts people before diagnoses. So that should inform how we speak to and about clients. For example, we should be using person-first language, discussing people as someone with schizophrenia rather than a schizophrenic person. And it should also inform how we understand people as whole selves and not just a collection of diagnoses. In addition, there's a growing recognition among those of us that work with those with mental health conditions that wellness is not simply the absence of illness, but that it involves life satisfaction, participation in relationships, leisure, employment, etc. Finally, although we can lose sight of this at times, I hope we all, as career practitioners and mental health workers, recognize the potential for growth and change in our clients. Our sense of hope for our clients, if we believe it to be true, engenders or increases hope in them in turn. So there are, in such a short time, it would be absolutely impossible to provide overviews of all the conditions that affect mental health. There are a lot of online resources where we can direct you for further information that will be provided at the end of this webinar. So here are a few categories of mental health conditions that I've chosen to highlight that you're likely to encounter in your work. Now keep in mind there are many ways to try and summarize all of this information. For efficiency, I've organized it in line with the new Diagnostic and Statistical Manual, DSM-5, but there are many other ways I could have chosen to do so. As always, remember that a given condition manifests in different ways across individuals. The same individual can vary in their experience of mental health symptoms over time and context. Never reduce a client to a diagnosis or a set of symptoms. So there are mood disorders, which would include things like depressive disorders and bipolar disorders. We're going to look more closely at major depressive disorder and bipolar disorder. There are anxiety disorders, which might include things like social phobia, panic disorder, generalized anxiety disorder. There are psychotic disorders that include schizophrenia and schizoaffective disorder. We'll take a closer look at the symptoms of psychosis and schizophrenia. There are obsessive compulsive and related disorders that include obsessive compulsive disorder, body dysmorphic disorder, etc. And we're going to highlight specifically OCD, or obsessive compulsive disorder. And finally, I'll talk very briefly about substance-related and addictive disorders. So I've chosen to start with major depressive disorder because it's one of the most common presentations for individuals with mental health concerns. People with major depressive disorder may manifest numerous symptoms and that are usually a combination of a depressed mood most of the day or flat mood, reduced interest or pleasure in all or most activities, a significant change in appetite or weight, increased or decreased sleep, motor slowing, fatigue or loss of energy, feelings of worthlessness or guilt, and impaired concentration. In many instances, there can be increased suicidal ideation as well. It's the most common of all mood disorders and in fact affects about 13% of Canadian adults at some point in their lives. Usually occurs or first appears in adolescence or young adulthood, though a first onset late in life is not uncommon. From a career perspective, it's important to know that major depressive disorder is one of the leading causes of work absenteeism and is a leading contributor to global disease burden in people ages 15 to 44. For people with bipolar disorders, in addition to experiencing one or more episodes of major depression, they have also experienced one or more episodes of mania or hypomania, which would be a slightly less intense form of mania. So what is mania? In people that experience mania, they may feel an extreme sense of optimism, euphoria, or feelings of special importance. They may have rapid racing thoughts that they find difficult to control. Their movement may become excessive and their speech can become rapid and pressured. They may experience a decreased need for sleep and increased irritability, at times even to the point of agitation or paranoia. And during a manic episode, there can be impulsive or reckless behaviors such as increased spending. So what does this look like for a career practitioner? An individual, a client with bipolar disorder may come across as disorganized during a manic episode, and they may not recognize that there is a problem. So it's important to collaborate with their care team to make sure that their symptoms are being managed appropriately. There may be issues of impulsive spending that you may need to help clients deal with. So for example, racking up large credit card debts or being prone to impulsive job changes. Anxiety disorders are really a cluster of different disorders that resemble one another in terms of excessive fear or anxiety. The difference between them is simply the types of objects or situations that provoke that type of fear, fear and anxiety. So examples include specific phobia, where someone has a fear of a specific object or thing like an animal or heights. Social anxiety disorder, which is also sometimes referred to as social phobia, where the person is afraid of social situations, conversations, eye contact, those types of things. Panic disorder, where a person is prone to having frequent panic attacks and excessive worry about future panic attacks. Agoraphobia, in which individuals become very afraid to leave their home or be in open spaces. And generalized anxiety disorder, which is the most common of the anxiety disorders, in which people have anxiety about many aspects of their life, which they experience as uncontrollable. All of us feel anxious and afraid at times, and it's tempting to think that people with anxiety disorders are just not good at coping with a normal situation. But the difference in an anxiety disorder is the pervasiveness, the excessiveness, and the persistence of the anxiety and the major effect it has on your ability to function. In an employment setting, we have to be very conscious of people that are experiencing anxiety. Entering a job interview, for example, is anxiety provoking for the best of us. But for someone with an anxiety disorder, you have to magnify that anxiety manyfold. Their symptoms may or may not be visible. They may not be obvious. And they may have difficulty in working with you recalling all the things that you ask them to do because their anxiety is impairing their concentration. Obsessive compulsive and related disorders is a new category in the DSM-5, not a new diagnosis, but a new category. It's closely related to anxiety disorders, but it's now been separated out into its own category. And I'm just going to focus on obsessive compulsive disorder, as it's something you may find being overrepresented in the clients that you work with. About 1 to 2% of the Canadian population will have an episode of OCD. The symptoms are a combination of obsessions, which are unwanted, distressing thoughts, ideas, images, or impulses, and compulsions, which are behaviors, rituals, or mental acts that people with OCD do to ease the anxiety that are caused by their obsession. People recognize that their obsessions and compulsions are excessive or unrealistic, but they're unable to change them. OCD can cause really marked distress in people and can be very functionally disabling. So obsessions may relate, for example, to germs. So working in certain settings may be very difficult for people with OCD. There may be very lengthy, complex rituals that they have to go through that make it difficult for them to leave the house for extended periods of time or certain times a day. The good news is that treatment is very effective for OCD. A combination of medications and therapy that involves exposure to the feared situation, and in combination with cognitive therapy, has a success rate of about 75%, according to the Canadian Psychological Association. And when stabilized, people with OCD may have a lot of unique strengths, such as attention to detail, precision. Mariella mentioned to me a client that's with OCD who's done well at software testing and quality control because of their excellent attention to detail. Post-traumatic stress disorder is certainly something that I see overrepresented in the clients that I work with. So when I say overrepresented, I mean there are more clients that present to me with PTSD than you would meet in the general population. Trauma is common. So according to the Centre for Addiction and Mental Health, 76% of Canadian adults report some form of trauma exposure. And of them, almost 10% meet criteria for PTSD. At least an estimated 50% of all Canadian women and 33% of Canadian men have survived at least one incident of sexual or physical violence. There are many symptoms of post-traumatic stress disorder, and they vary from person to person and across time, but they fall essentially into 4 categories. There are intrusive symptoms, where people have intrusive or distressing memories, nightmares, feelings of dissociation from the event, or a physiological arousal after triggers for their trauma. There are also avoidance symptoms, so avoidance of thoughts, feelings, and external reminders like people or places that remind them of the trauma. In addition, there can be negative alterations in their cognition and mood, so for example, amnesia for the event, negative beliefs about the world or others, like I can't trust anybody anymore. There may be persistent negative emotions such as guilt and shame, and constriction of their affect, or how they express emotions. There can also be alterations in arousal and reactivity, meaning that they may become, people with PTSD may be irritable or aggressive at times, self-destructive or reckless. They may be hypervigilant to their environment and have an exaggerated startle response, have problems with concentration and sleep disturbance. Working with clients with PTSD can be challenging at times. It may be difficult to form a rapport with such clients because in many cases they have been traumatized to such an extent that it's difficult for them to trust people that they interact with. Keeping to a schedule can be important, and probably more than anything else would be learning about how to develop a trauma-informed practice, which is different from a trauma-specific service. There are many guides on this process, but it really involves taking into account trauma into all aspects of service delivery. So putting a priority on patient safety, choice, and control, creating a culture of nonviolence, learning, and collaboration. It doesn't require disclosure on the part of the client. It's really a focus on safety and engagement and avoiding further traumatization, keeping the client in the driver's seat and making decisions about a treatment that at a safe pace for them. I mentioned psychosis because it's often misunderstood. Psychosis is not a disorder, but a set of symptoms. And psychosis may be seen in a variety of different conditions, whereas most people associate it with schizophrenia. Psychosis includes things like hallucinations, in which you see, hear, taste, feel, or smell something that others cannot. Delusions, so a belief held with conviction despite strong evidence to the contrary. For example, the belief that someone's thoughts are being controlled or that the government is out to get them. It may include catatonia, so a person does not move, respond, or interact. And often manifests as a thought disorder, which to observers looks like very disorganized speech that we often call word salad. Psychosis may result from a variety of different situations. For example, intoxication, extreme sudden stress, or a medical condition. And so a new onset psychosis should always be alerted, the family physician should always be alerted for prompt assessment. But if those things are ruled out, psychosis can be the symptom of a larger mental health condition such as schizophrenia or bipolar disorder. And research today shows that early identification and treatment is crucial to long-term outcomes for people with psychosis. Schizophrenia is a complex disorder, or depending on who you talk to, group of disorders that involve psychosis as a component. It affects about 1% of the population, though again, these individuals are likely to be overrepresented in employment programs. People with schizophrenia present in varied ways, but common symptoms include psychosis, so hallucinations and delusions and disorganized speech, as well as catatonic behavior. But there are also negative symptoms, which are symptoms that involve when somebody is missing something that typical people demonstrate. So, for example, blunted affect, disinterest in things, slow movement, lack of responsiveness, not paying attention. And those are the symptoms that are often refractory to medication. That is, medication doesn't always make those symptoms better. This can be really challenging for families and career practitioners alike, where they may mistake negative symptoms for clients being not paying attention, being disinterested, or lazy even. But the important thing is that with proper treatment, even people that hear voices and have delusions can learn to manage their voices and other symptoms and can lead full and productive lives that include employment. Finally, I'm going to talk about substance abuse or substance use disorders. Substance use disorders cut across every category we can think of. So it cuts across age, ethnicity, disability, gender, socioeconomic status. And so they need to be attended to by people who work in our field. About 20% of people with a mental health condition have a co-occurring substance use problem, according to research. In my personal experience, that number tends to be much higher. The use of substances is a common coping strategy for many of us, and when used infrequently, may not be harmful. When we consider it a problem, and when we might call it a disorder, is when someone is stuck in a cycle of using a substance in increasingly larger amounts, where they're unable to reduce or abstain despite wanting to, and they have cravings for the substance when it's not present, and when it has a significant effect on their ability to function in life. And in many cases, it may involve a physical dependence on the substance, so developing a tolerance or withdrawal symptoms. In mental health, we're noticing a trend of increasing integration between mental health and addictions, and for good reason. There's so much overlap in those two areas. And in British Columbia in particular, we are moving towards a harm reduction and strength-based approach in which it's important not to view substance use disorders with judgment or as criminal justice issues so much as we view them as chronic health conditions, chronic diseases, in fact, that warrant ongoing treatment. Now, unfortunately, there are dozens and dozens of other disorders and conditions that we could have dedicated time to today, but we simply don't have the time. Personality disorders, I'd like to just highlight briefly as being a collection of disorders that are, what unite them is their chronicity. So that is that there are disorders that begin in childhood and continue across the lifespan and have to do with the way people act interpersonally and how they come across to others. And clients with personality disorders can be challenging to work with, and Marielle and I would like to recommend the importance of setting clear boundaries with clients with personality disorders, having clear expectations about what is and is not available, and just try to avoid it becoming enmeshed or creating unrealistic expectations for people. We also could have talked about neurodevelopmental disorders like fetal alcohol spectrum disorder, ADHD or learning disabilities, or even feeding and eating disorders. So please do take the time to learn more about those conditions using some of the links at the end of this presentation. Okay, only about 10 minutes left to go, so I'm just going to keep rolling here. All right. So one of the things that I was asked to talk about is helping career practitioners. Oh, I'm missing a couple of pages here. That's all right. I'm going to borrow Mariella's. 10 and 11. So is helping to identify clients with mental health issues. So at the beginning of the presentation, thank you, Mariella, Susanna led a poll and asked you whether you thought it was more difficult to work with people with mental health conditions versus physical health conditions. And the majority of you felt that mental health conditions were more difficult to identify and perhaps work with. And I can understand how that would be the case, because unlike a physical illness, mental illness or conditions are often invisible. We can't see them on the outside. So how do we go about identifying clients who have mental health issues? Well, I'd like to start by saying we need to create safe spaces for clients. Many of our clients have been traumatized repeatedly and have come to lack trust for the system. So we need to create spaces where clients feel that they're not being judged and that they have the latitude to discuss the issues that are important to them and the challenges they have. Secondly, it's important to just have the conversation. Don't assume that a client with mental health issues is going to raise those concerns spontaneously. Every client you work with, this should be a topic of discussion. Ask questions like, I noticed in the past that you have had involvement with the mental health system. Would you like to tell me about that and the different struggles that you have? Always be alert for changes, especially sudden changes in clients' mood, appearance, or behaviors, because this can be a strong signal of a relapse, recurrence, or worsening of symptoms. Ask clients questions like, I noticed you've missed a couple of appointments lately. That's really uncharacteristic of you for you. Is something going on that we can talk about? I noticed that you seem a bit distracted today. Are your voices bothering you? So don't be afraid to have the conversation. And of course, that's going to be based on building a trust and rapport with the clients so they feel safe. I always advocate for coordination of care, so collaboration between care providers. So in other words, if you identify a concern, share that with the relevant stakeholders in that client, so their family physician. And as the next point says, having family engagement and social network engagement is key. Get informed. So obviously you're doing that. You're attending a webinar right now. There are a lot of other resources available. You can take a course, for example, through the Mental Health Commission on mental health first aid. There are various webinars, seminars, and other conferences that you can take to arm yourself with more information. And when we were reviewing the slides this morning, Mary Ellen made an excellent point that I'd like to add, which is that in developing our own competencies around mental health, we can also try to equip our clients with that knowledge. So when you find these resources, sharing them with clients, they have a better self-understanding is key. In working with clients who have mental health conditions, the core principles that I always try to adhere to are empathy, warmth, and hope. So coming from a place of understanding and non-judgment, having a warm demeanor with people so that they feel comfortable, and really believing in the potential for growth and change. If we don't believe that growth and change is possible, then our clients will not believe it either. We have to be flexible when working with clients with mental health conditions. So we may have an agenda. This may be session 2, and we're working on resume building today. But the client has had a suicidal crisis that weekend, or they're in a manic episode. We have to be able to be flexible and change our approach, meet clients where they're at. Collaboration and consultation is key. Even myself, having my doctorate in clinical psychology, at times can feel out of my depth with certain clients, and that's when consultation and referral to specialists is key. We're always keeping client-centered philosophy at the forefront of your mind. So that is seeing people as people and not as diagnoses, seeing their strengths and keeping them in the driver's seat. Also managing your own self-care. Marielle is trying to give me a signal, but I'm not quite sure what it is.
No, you're good.
Okay, so I just want to take a little bit of time. This is basically the last thing that I'm going to talk about because I think it's so crucial, and that's identifying suicide risk. So for many of us who work with mental health, the idea that we might lose a client to suicide is terrifying. And quite frankly, it's something that we may experience across our careers. Suicide is most often the result of profound pain, hopelessness, and despair. It's the triumph of pain, fear, and loss over hope. That's a quote from Working with the Client Who's Suicidal, a toolkit for adult mental health and addiction services. You can find these documents online, and I strongly encourage you to read them. They discuss suicide assessment and how to support someone who is having suicidal thoughts. And the crux of it really has to do with asking the questions, listening non-judgmentally, and helping clients develop a safety plan and helping them to access the resources they need, involving the family, and when a crisis seems imminent, helping them to get to a hospital. There's also 2 mnemonics that I've included here that help you to remember some of the factors that increase risk for suicide. So most people who have suicidal ideation do not go on to commit suicide, but all risks should be taken seriously. Importantly, a lot of people are afraid that having the conversation about suicide will increase the risk, but the opposite is true. Having the conversation with someone about suicide does not increase their risk of attempting and most likely decreases their risk. So don't be afraid to have that conversation with clients. These risk factors include things like having ideation about suicide, so talking about not wanting to be here anymore, wanting to disappear, wanting to end one's life. Increased substance use. When the client starts talking about feeling a sense of purposelessness or hopelessness. Increase in anxiety. When they start to talk about feeling trapped in their life, feeling hopelessness, withdrawal from family and social networks, anger, recklessness, or a sudden change in mood. And then on the right there, I won't go through all of these in the interest of time, but these are another way of conceptualizing things that increase risk. Okay, only a few more minutes left to talk about treatment, and I had a feeling we might run out of time here, so I'll go through this fairly quickly. One of the most effective ways to treat different mental health conditions are with medications. These are prescribed by a physician or specialist physician such as a psychiatrist. They all work differently, but mostly what they do is they alter the availability of chemicals in the brain that are involved in mood. Although, to be honest, nobody really understands how some of the medications are as effective as they can. They treat symptoms and they're not a cure. Clients may be on medications for short or long period of time. They may be combined, so more than one medication for best effect. And they may be combined with other interventions as well. Medications affect people differently, and they may have side effects. When working with clients who are on medication, it's important to ask them how compliant they are with their medications. If you know of a client that is stopping their medication or messing around with their dosage, I strongly encourage you to have them discuss this with their physician because it can be dangerous to do so. In addition to medications, there are a variety of different therapeutic or counseling ways to treat mental health conditions. This might be done on an individual or group basis. There are various theoretical orientations and different training backgrounds. So therapy or counseling may be performed by a psychologist like me, a psychiatrist, a counselor, a registered counselor, psychiatric nurse, a mental health worker, or many other individuals. It may be a very brief process or a long-term. And the take-home message here is that research suggests that therapy is as effective as medications for treating most mental health conditions. And research also suggests that for many conditions, a combination of medication and therapy leads to the most lasting and meaningful results. But there are other types of interventions. What we're going to be focusing on is what Mariella introduced at the beginning of the webinar and what she'll discuss in further detail in the next webinar, which is Principles of Psychosocial Rehabilitation. These are interventions that we can all use. We don't need to be a PhD in psychology to employ these skills. All right. So I'm hoping that these slides will be made available because we're going to go through these last ones quickly, but here are some great websites where you can get just endless resources on working with clients with mental health issues, specifically with an employment lens. I would like to give special props to the Mental Health Commission and Mental Health Works, as I found those particularly helpful. And then there's also Guarding Minds at Work, which is a program developed at Simon Fraser University, which is chock full of great information. I've also included on here a few useful websites specific to different mental health conditions, which you can use to learn more, and you can point families and clients to these resources. So just to conclude, one of the things that we were in the feedback in preparing this talk was looking at, if you live in a remote area, how do you get access to some treatment? And we want to advocate getting creative, and this is one online program created by one of my colleagues, Dr. Christine Coral, who's a registered psychologist, and she actually provides online sessions for treating anxiety that are free of charge for anybody who logs in. So here's an example, a short clip. Hi there.
Here, I'm Dr. Christine Coral, and welcome to Class 1 of Quieting Your Anxious Mind. So what we're going to do in this course is really teach you some of the ways to let go of some of the anxious thoughts that keep swirling around in your head and learn how to tolerate uncertainty and look at the evidence and have it actually convince you rather than having people just reassure you and you don't really believe them. And you're going to learn a lot about why it is that you worry, what keeps worrying going, everything you need to know, everything that I teach people in my office. So I'm hoping you find this very helpful, and we're gonna jump right in.
All right, so that is basically the conclusion of our first webinar. We look forward to hearing your questions and getting your feedback. We'll be holding our next webinar on Wednesday, April 23rd. I think Susanna is going to speak to that. I'll turn it over.
Thank you. Thank you very much, Sarah and Mariella. That's wonderful. It was very informative, and I really appreciate how you linked it back to for practitioners. And we're looking forward to the next webinar. And now I'm going to turn it over to Greg, who will be asking some of the questions that we received from the audience.
Yeah, we still have a couple of minutes, so if you do have a question, please use the questions tab in the panel and submit that. The first question we have came in, person wanted to know about the article that was mentioned at the beginning of the webinar.
Okay.
I'm not sure if you have that, Sarah.
Let me just take a peek. Are you talking, I wondered if they were talking about the aspiring workforce, which I did mention early in the webinar. And it absolutely is something that I encourage you all to read. And if you look in the references of our talk, it's number 5. It's available online, and it's produced by the Mental Health Commission of Canada. And the full title is The Aspiring Workforce, Employment and Income for People with Serious Mental Illness. It's really useful, so for sure look that up.
Okay, thanks, Sarah. And just to confirm, we will be posting all of these slides on the center's website tomorrow, and they'll be sent out in a link in an email that you'll receive tomorrow as well. Someone is asking again about the second part of the webinar series on mental health, and again, the date for that will be April 23rd. Same time, same place. Registration link should be made available in same email tomorrow. Otherwise, please continue to check the center's website to sign up for that. And again, we have about a minute left, so if you have any questions, please send them in. If you don't, or if you have a question that comes up later on this afternoon, please feel free to post to the blog post with the link to the webinar, and I'm sure Sarah Jane, and Marielle will be happy to respond to any questions. Okay, I think that's it for today. No more questions are coming in. So we're just going to take a look at a description for the next webinar, so you have an understanding of what will be highlighted on April 23rd. So again, in tomorrow's follow-up email, you'll also receive a link to a short survey. It will take about 1 or 2 minutes, and your feedback will help us immensely for planning future webinars, including parts 2 and 3 in this particular series. Mariella and Sarah are very keen to hear from you about any topics you would like to see included in the next 2 webinars. So again, if you participated in this webinar with a colleague or in a group, please select the most appropriate or common answers. And thank you in advance. So again, the second webinar will focus on applying principles of psychosocial rehabilitation and recovery to successfully engage clients in the supportive employment process. Sarah and Mariella will review skills and tools for assessing readiness, as well as strength-based approaches to client goal setting. Specific recovery tools and strategies for wellness in the workplace will be introduced. Finally, they will introduce the value of engaging the client support network in facilitating work integration. Okay, and with that will end our webinar for today. So on behalf of the BC Centre for Employment Excellence, thank you and have a great afternoon.